So continuing with the cardiovascular system, I just want to emphasize that, remember, the atria contract together, sending the extra blood coming into those ventricles. That last 20% contracts, sends that blood to the ventricles, and then the ventricles contract together. The right side of the heart sends it to the lungs. The left side of the heart sends it to the body through the aorta. So it's a side-by-side pump serving the lungs and the body at the same time. Key topic question. So here we can kind of see it. The blue side here is the pulmonary circuit. So we call it the pulmonary circuit. So it's pretty short, right? It pumps from the ventricles to the lungs and then back via the pulmonary veins to the left ventricle. Then the left ventricle sends it out the aorta up to this would be like the common carotid, right? Sending it to the head. And then the abdominal aorta taking it down to the lower part of the body. So the left side of the heart we call the systemic circuit. The right side of the heart we call the pulmonary circuit. Pulmonary referring to the lungs. So what do we know about the sides of the heart? Volumes. Is there a difference in the volumes? Left and right side? No. There is no difference in volume of blood. Is there a difference in pressures? Yes. Which side has more pressure? The left. So which valve do you think fails and people come in to get repaired when they're 85 years old over a lifetime of heart contractions? Left AV or right AV? The left AV. Yep, the mitral valve is a common one that needs to be replaced. How about pulmonary valve or aortic valve? Aortic valve, yep, because that comes from the left ventricle, right? So that's another valve that can become problematic. So higher pressure on the left, and by looking at the heart, we can tell it pumps under higher pressure because of what feature? Yeah, the thicker wall on the left ventricle side, right? This wall here is thicker, and we know that it pumps under more pressure because of that. Again, equal volume, so you can see bolded, underlined, those are hints for test questions, right? So if I look at how the muscles are arranged in the heart, we can see they wrap around almost in a circular kind of motion around those ventricles. And the reason for that is, think if you're trying to empty this heart, think of how you try to empty a rag. When you really want to empty that soaking wet rag, what do you do to the rag? You twist it, right? You twist and squeeze from the bottom up. So that's what happens with our ventricles. The way those muscle fibers are arranged, it has almost a twisting motion to really squeeze that blood out of the tip of those ventricles, out of the apex, and get it to go upward into the different arteries leaving the heart. So these muscle fibers are also separated by connective tissue. So when an action potential goes down the conduction pathway that we're going to learn about, the whole heart doesn't contract at once, because we want the atria to contract first, right? And then we want the ventricles to contract. So we want the ventricles to contract starting with the outer walls and working its way upward. So we're going to see how that happens in the conduction pathway. So connective tissue is what separates the cells from one another, so we don't get the whole heart contracting as a big unit. We want it to contract atria first, ventricles second. Okay, so there's a specific pathway and a time delay between the atria and ventricular contraction. So if we look at those cardiac muscle cells, we already talked about this in lab, but if I look a little closer here, I can see that my muscle cells are separated by these intercalated discs, which are these darker lines. Well, there's two things on the intercalated disc. So there's two things we find at the intercalated discs. The reason why they stain more dark in color is because there's two protein structures that pick up more stain. So more than just the striations, there are striations there. We can see them a little better on this diagram here. These are the striations. But the intercalated discs have two things. They have gap junctions and they have desmosomes. You need to know the functions of both of those structures. Gap junctions are just doorways. They're passageways between cells. So if I have an increase in sodium in one cell, those sodium ions can flow through the doorway, flow through the gap junction to a nearby cell, and increase the millivolts in that nearby cell, causing depolarization in the nearby cell. So these are doorways for ions to travel. So an action potential, if it starts in one cell, it can easily flow to the next cell. Those ions that contribute to the action potential flow through the door and cause depolarization in a nearby cell very quickly. So really, really important for spreading of action potential are these gap junctions. Another one are desmosomes. Desmosomes, think of them as like shoelaces tying those two cells together. So when one cell contracts, it pulls the nearby cells with it together. So the heart can contract as a unit. So that part of the heart, so for example, when the ventricles are signaled to contract down that conduction pathway, both ventricles contract as a unit at the same time. We call that a functional syncytium. This fancy word here, functional syncytium. It just means it functions as a unit. So that's what that means. It contracts as a single unit. So if you want to define this term, just highlight or underline contracts as a single unit. And that's what the desmosomes and the gap junctions do. They allow it to contract as a unit. Again, the desmosomes tie the cells together, and the gap junctions have passageways for ions to flow and that action potential to spread very quickly. We don't see that in a lot of cells in the body. Most of the cells, require an action potential to travel down the membrane. The skeletal muscle cells, they don't have gap junctions. Cardiac muscle cells do. And we're going to find some of our smooth muscle cells also have gap junctions. So gap junctions and desmosomes are found at the intercalated discs. So two things are found there. That's the key concept. Two things. The desmosomes and the gap junctions are part of what we call an intercalated disc. So the disc itself doesn't have a function. It's what makes up the disc is what determines that function. Okay, so action potential in cardiac muscle cells, a little bit different than skeletal muscle. You're not going to need to know the nitty-gritty details of these action potentials until you get to advanced A&P, but I'm going to introduce them here so you know they exist. So key ions for the cardiac action potential are sodium, potassium, and calcium. Calcium is the difference, right? Did we see calcium playing a role in skeletal muscle contraction? Do you remember the action potential? What causes the depolarization, the upward sweep? What ion is involved in the upward sweep depolarization? What is it? Sodium. And then coming down, potassium. And then we're done, right? That was the end of the action potential. So in cardiac muscle cells, calcium plays a role. So we need a balance of all these ions for the heart muscle to contract properly. And if we see imbalances, we see arrhythmias, okay? So let's talk about the types of heart muscle cells. 99% of the heart muscle are contracting cells that need an action potential to be generated by some other cell. They're the slaves of the heart muscle. They just contract when they're told to. 1% of the heart muscle cells are called pacemaker cells, and they can contract, but very weakly. Their job is really to just initiate an action potential all by themselves. So I can take a heart out of someone else, put it in another body, not hook it up to their nervous system, and it'll contract on its own because of these 1% cells. The heart has its own intrinsic nervous system to beat. It does not need help from the nervous system. But does the nervous system help it? Yes. If I think something stressful, can I get my heart to beat faster? Or if I try to relax and practice mindfulness and meditation, can I lower my heart rate? Yes. So when it is hooked up to the nervous system, we can influence it, but it's not required. Okay, so the heart can beat by itself. So pacemaker or autorhythmic, auto means self, it means they don't need a nervous system to tell them what to do, but it's only 1% of cells, and they're found on that conduction pathway that we're going to talk about. So those parts are clusters of cells at the SA node, the AV node, the bundle of His, bundle branches, and Purkinje fibers. These are part of the conduction pathway that can generate their own action potential. So when we look at these parts of the heart, so let's go to our picture. Here's the conduction pathway. So the SA node is found at the top of the right atrium. The AV node is found at the bottom of the right atrium. Then we have the AV bundle And then it separates and goes down. We call these bundle branches. And it comes up those outer walls, and these are called Purkinje fibers. Purkinje fibers. So each of these parts has its own rate of action potential generation all by itself. And we'll talk about how it can do that, what those cells, how those cells are specialized to do that. But this one can generate action potentials at the fastest rate. So because it's the fastest, and because once this generates an action potential, that action potential, because of connective tissue pathways, travels right to the AV node. And then that action potential goes down the bundle of His, then down the bundle branches, and then up the Purkinje fibers in that order. That's why it's numbered 1, 2, 3, 4. That's the order the action potential generates. So if this is the fastest, then it doesn't matter what these can generate an action potential at, because this is boss. This is doing it faster than anybody else. Okay, so think of it as assembly line of people wrapping gifts. And if you're sending your wrapped gift down the line, and the person at the front of the line at the SA node is wrapping it the fastest and sending it to the next person, if that person's not done wrapping their gift, well, they're just going to pass that down to the next person, right, that wrapped gift. So it's the same thing with this. If it's generating it the fastest, it's going to pass down, and these other parts don't need to generate their own action potential because this one's boss. It does it at the fastest rate. So the different rates for the different parts are up here on page 374. So the SA node can produce action potentials about 70 action potentials a minute. Yes?
So there's also
It probably depends on the textbook. Sometimes there's a little variation. Where are you seeing that?
It's on 77, 77 on the diagram down below.
75, yeah, 70 to 75. Well, I'll talk about that. So here's the thing. Actually, the SA node, if it's not connected to the nervous system, it can generate action potentials at 100 beats per minute if we disconnect it from the nervous system. So 100 beats a minute. That's a little high, isn't it? But with the help of the parasympathetic nervous system that synapses or stimulates the SA node, that can bring that heart rate down to 70 to 75 beats a minute, because that's our resting heart rate, right? But again, if I disconnect it from the central nervous system and I just have that heart and that SA node all by itself generating its own, it can go as high as 100 beats per minute.
So what's happening with the twisted AFib where you're getting atrial?
We'll talk about that. Okay, so so we're here. So the SA node, 70 beats a minute with the help of the parasympathetic nervous system. Again, if the sympathetic nervous system is on overdrive, we can get as high as, 200 beats a minute. Someone's really stressed out, they can get their heart rates really high. Exercise, all that stuff. So the AV node is slower, 40 to 60 beats a minute. Bundle of His Purkinje fibers, 30 to 40 beats a minute. So if someone has a heart attack and they damage some of the cells on the conduction pathway, and someone has some type of block, we call it a bundle branch block here. So what happens is this high, fast rate can't pass through these fibers because they're damaged from heart attack. What happens? All we have left are the Purkinje fibers to generate heart rate, and their heart rates are really low. They're in the 40s because of damage to this conduction pathway. So when people have heart attacks, they can end up with deadly rhythms because of damage to the pathway. So your question about atrial fib is it's a common thing to have a cell generating an impulse, say at 80 beats a minute, but because of damage to the pathway, it circles around and comes back and stimulates it again. So you have these run-around action potentials stuck up in the atria, and people can have, really rapid atrial contractions as a result of that. Yeah, and it's just because of this damaged conduction pathway, and then it just running around. Other times, too, we have something called ectopic beats, which means some of these cells that are off the pathway are sending beats to the ventricles all by themselves. We call those PVCs, premature ventricular contractions, where we have cells that are generating their own action potential outside of the normal rate. So we see a lot of this stuff, and it's a very common thing. PVCs are a very common thing. Maybe some of you have noticed when you lay down in bed at night, you're laying there quiet, all of a sudden your heart goes boom, 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 in between its regular beat. And you wonder, what is that about? That is a very common thing with dehydration, lack of sleep, stress, and caffeine. Those are #1 causes of premature ventricular contractions. Very, very common, most often completely benign. It's always good to get it checked out. And they often go away at higher heart rates. So we don't notice them when we're navigating our day and walking around the halls and doing our thing. We don't notice them. But when you go to sleep at night or lay down and rest, all of a sudden your heart rates are going down and you have these extra beats that you're noticing. Oh, apnea, that's a different thing. We'll talk about that when we get to the respiratory system. So hold that question. Yeah, hold that question. Yeah, we'll talk about that. We'll talk about that. And remind me, but we'll talk about that. Okay, so back to this. So let my question to you, which would be a test question. Person has a heart attack, damages the SA node. Sorry, I'm sliding through these slides so much here. I want to go back and forth to this diagram. So someone has a heart attack, and they have damage to the SA node. Well, the atria fail to contract. Why not, Nicole? Exactly. The AV node will take over. But will their heart rate be the same rate? No. Will it be faster or slower? Slower, because we know the AV node beats at a slightly slower rate, right? Okay. So the same thing. If this whole thing breaks down, the ventricles will still contract, and the Purkinje fibers will be boss on that, right? So when people get a pacemaker, they need some electrical device outside of the conduction system to kick in if something happens. And I have a pacemaker here I'll pass around to show you. So what they do is they implant this under the skin, and it has wires that go to the atria and the ventricles, depending on the type of chamber, dual chamber. Some are dual chambered. And they will stimulate those ventricles only when necessary. Other people, their conduction system is shot, and it's constantly stimulating the ventricles to keep them alive. So some are just like a defibrillator. They kick in only when necessary, and others are constantly stimulating. We call it being paced. And we'll talk more about that in advanced A&P if you have to take it. But I'll pass that pacemaker around, and it's pretty big. You can feel it and see it under their skin. And that's something we do on our floor all the time, is monitor patients that just had a pacemaker put in. Okay, so back to this then. If we look at the action potential of a cardiac muscle cell, this is a skeletal muscle cell. This is what we've already studied. So this is sodium coming in, then those voltage channels close, and then this is potassium moving out, and it becomes negative again, right? If we look at a cardiac muscle cell, we have a little difference here. But it's the same on the rise and the fall. So sodium is moving in, and then it shuts. But at this level is where calcium channels open, and because calcium is more common outside the cell, when we open up a channel for it, calcium wants to move in what direction? Into the cell. That's going to keep it positive, right? It's not going to drop down and become negative if we have a positive ion flowing into the cell. So this flattens this curve out a little bit, and then those calcium channels close, and the potassium channels open. And remember, potassium is in higher concentration inside the cell, so as it flows out, positively charged potassium flows out, we see this drop. So what's the benefit of having a delay in that action potential? We call that a plateau. And the plateau is due to calcium channels being open, and calcium, positively charged calcium, flowing into the cell. We only see this type of action potential in our contracting cells. In 99% of muscle cells, this is the action potential they have. So this is the 99% of cells. Make sure you mark it as that. Okay, so we have this plateau phase. Again, 99% of muscle cells have this flattened spot. So I have the squeeze, so that delays the squeeze a little bit. Because if I look at tension development, it delays that squeeze a little bit before it relaxes. And what is the benefit of that? It allows more time for the heart to fill with blood, as well as empty with that squeeze. So when I have a delay, because right, when there's a slight delay in that action potential, that gives time for the ventricles to fill. And then when it's contracting, it's squeezing completely and allowing it to empty. So we don't have rapid heart rates or rapid action potentials like we see in skeletal muscle where we want a lot of strength. We have a slight delay between action potentials because of the plateau. And that means when the atria are firing, there's a slight delay before the AV fires and a slight delay before the Purkinje fibers fire. Again, allowing each chamber to completely fill and completely eject their blood. So how do they spread? That's sodium and calcium and potassium through those gap junctions. So it happens very rapidly in a specific part of the heart, again, separated by connective tissue, to allow that to happen as a unit. So the atria contract together, the ventricles contract together because of those gap junctions for those ions to flow. So the plateau phase we see in contracting cells, 99% of the heart muscle cells, and it's calcium that causes that plateau phase. So we talked about the conducting system, the parts of it. So now let's look at that. And that is, what does their action potential look like? How are they generating, thank you, how are they generating that action potential? Well, they have special channels that drift open automatically when we get down to this negative 60 millivolts. So as potassium channels are open and that is drifting down to negative 60, at negative 60 we have sodium channels automatically opening when we reach negative 60. So when they automatically open, it drifts toward threshold, which is negative 40, and then we have rapid opening of channels at number 2. Now the interesting thing though is what opens at number 2. Here's a difference. We have slow movement of sodium in, so we have these automatic opening channels for sodium here. We call this the pacemaker potential because only pacemaker cells have it. Only those conducting pathway cells have these slow, automatically opening sodium channels. Once it reaches threshold, bam, calcium channels open, and we see a rapid increase in our millivolts going positive. So this is the depolarization. And then we hit to the top, again, potassium channels open, bringing it back down to the negative values. When we hit negative 70, all those potassium channels are closed, and then those slow opening sodium channels open again and drift toward threshold. So this is unique to these pacemaker cells, are these special channels that open all by themselves without a stimulus, right? There's no stimulus for this. It's just the millivolt levels in those cells when the potassium channels finally close. So if you look at all 3 types of action potentials we've talked about, skeletal muscle action potential, it's just sodium and potassium. Cardiac muscle, it's sodium, calcium, potassium. Here too, sodium, calcium, potassium. So the order of ions involved is the same in both types of cardiac muscle cells. It's just the shape of the graph that changes. So I would recommend just really focusing on that. This just, kind of looks like a skeletal muscle action potential a little bit, doesn't it? It's a little wider though than the skeletal muscle action potential, but it's sodium, calcium, potassium. And going back to this one, take the one by itself, it's sodium, calcium, potassium, just a different shape. So just practice drawing those shapes out. And if you just remember sodium, calcium, potassium, you're not going to get any of those details wrong. And this is the skeletal muscle action potential, which is just sodium and potassium. So is calcium important in the body more than just keeping our bones strong? Hugely, right? We need it for the neuromuscular junction. We need it for muscle contraction. Hugely important in a cardiac muscle contraction. So that's why if we don't have enough calcium in our blood, our body is going to go grab it so we can keep our muscle, our heart muscle and our skeletal muscle contracting. So it's not a priority to keep the bone strong. It's your priority to keep your bone strong, right? So as women of reproductive age and those that are getting to the end of that, they really need to make sure their calcium stores are up, that your bone mass is where you want it to be. Otherwise, you're going to end up with osteoporosis as an older person. So weight-bearing exercise and a diet high in calcium is important for people of all ages and genders, but especially important for women of reproductive age, especially thin women of reproductive age, because they're not getting as much weight-bearing activity, especially if they're thin and not active and not getting any exercise. Those are the biggest patients that we see coming in for treatment for osteoporosis, are thin women that didn't exercise as young people. Okay, so the refractory period, cardiac muscle, because of that longer action potential, it's a wider graph, right? If you look at, especially the plateau phase, right, it's a wider graph, allows time for those ventricles to fill before the next heartbeat. Because what happens at really high heart rates? If your heart is in a fibrillation and it's contracting really fast, is it filling with blood if it's contracting at 200 beats or more a minute? No, unless you're exercising, right? And your heart is the heart is contracting stronger and you have more venous return. That's a whole different story. But if you're just sitting there and your heart rate is going crazy like that, that's dangerous. And you better go running to those rooms if you get a signal for that. If you work on a cardiac floor and someone has a really high heart rate, we need to assess that very quickly, because they can pass out and die from that if we don't restore that normal heart rate. So action potential is 200 milliseconds longer than a typical skeletal muscle cell. And again, we need that to give time for the blood to fill those ventricles, because tetanic contractions are constant contractions, and there's no time for the ventricles to relax and fill. So if I look at an EKG, it tells us about the action potential in a heart of a patient. So every EKG should have some distinguishing characteristics, and it follows the alphabet. So that this is a straight line, right? So anything that goes up or down we call a deflection. To deflect just means to move in another direction. So the first deflection is an upward deflection. It's called a P wave. And this happens when the atria depolarize. So when the atria generate that action potential and both of the atria depolarize, we see this bump on the graph, because I connect electrodes across the body, across the heart. And we're not going to get into details of that. That's a clinical class topic. But we put electrodes on the surface of the skin, and we can measure this spread of electrical current. And we see a P wave. So if I see a P wave and I see just one P wave, I know the atria contracted, and that's normal. Then there should be a slight delay as that P wave depolarizes. So the atria, the SA and AV node, there's traveling impulses there. You got an atrial contraction. Now it's got to travel down the bundle branches, up the Purkinje fibers, and then the ventricles contract. So that depolarization of the ventricles is shown by this narrow, tall, what we call a QRS complex. So this represents the ventricles depolarizing. So slightly after this, the ventricles are going to contract. So we can assume that the atria are contracting right in here, because the depolarizing event, the electrical event, has to happen first. So this is the depolarization, then the atria are contracting. Here's the depolarization of the ventricles, and then the ventricles are contracting in here. Then the T wave is when the ventricles are repolarizing, getting ready to relax. So if I see this nice space here, it's not lengthened at all, then I know I've got a nice normal sinus rhythm. And when we say sinus rhythm, we mean that the sinoatrial node is operating correctly and we have a normal EKG. The P wave, so the atria are depolarizing, followed by the ventricles depolarizing, followed by the ventricles repolarizing. Now what we don't see here are the atria repolarizing. Where do you think that's happening? It's hidden in a wave. Which wave do you think it's hidden so we don't see it by itself? Yeah, they're relaxing during the QRS wave. So maybe this would be a little taller if we were measuring the PRS, or if the the atria weren't repolarizing. Okay, so this is, each of these represents what's going on across the heart, right? So as long as we see this R, this represents the heart rate, because every time the ventricles are contracting, we know when, right as they relax, we hear that lub sound, right? The lubbed up, lubbed up. So, I'm sorry, right as they contract is the lubbed. I apologize. We'll talk about the cardiac cycle in a little bit. But the R wave really tells us heart rate. So this is one complete cycle of the heart. Atria contracting, ventricles contracting, ventricles relaxing, done. So this is one heartbeat. So we can measure heart rate by counting R waves. So if I see lots of P waves, that means my atria are depolarizing too much, and it's an abnormal heart rhythm, and we're going to study that in advanced A&P. So you can be glad if you don't need to take advanced A&P. This is the extent that you need to know, is just know a normal EKG pattern. What does the P wave represent? Depolarization. Don't say contraction, because they're not contracting yet. They're just getting ready to by this electrical event we call depolarization, which means sodium ion is flowing into those cells. Ventricular depolarization is the QRS, along with the atria repolarizing, and then the T wave, again, ventricular depolarization. Okay, so cardiac cycle then is looking at what's going on throughout the heart when we're looking at contraction and relaxation. So the term for contraction in heart muscle is called systole, and relaxation is called diastole. So I have a handout for you. It says Cardiac Cycle Review, and at the top of it, it also has a website you can visit that puts all these parts in motion together. So I want to go over that a little bit, but I have a picture here too that I'm going to show you. So contraction is systole, relaxation is diastole. It's not systole and diastole. That's what it looks like, right, if you sound it out phonetically, but it's systole and diastole. And if you watch shows like Grey's Anatomy, you know, they say, he's asystole, asystole. A means not. So what's the problem? The heart's not contracting, so they're essentially dead, right? So if your heart doesn't beat, you're dead, right? There's no pulse. We call that asystole. So we want systole followed by diastole. So make sure you know those two terms. Contraction is systole, relaxation is diastole. So here's the cardiac cycle in picture form. The handout that I gave you that's in the Blackboard folder on this topic called Cardiac Cycle Review shows you the graph of all the different things that are going on during this time. So let's identify what's going on in terms of these periods of the cardiac cycle. So we're still on my PowerPoint, not on the worksheet yet. So the first thing that needs to happen is the ventricles are filling with blood, and when the ventricles fill with blood, we call it passive filling in the first part because the whole heart is relaxed, the AV valves are open, and the veins, what are the veins leading to the atria? The right atrium has what veins leading to it? What veins lead to the right atria? Yeah, very good. Inferior and superior vena cava. And that, remember I told you to fill out the first page of the worksheet, the study guide that is in your packet for today, so you have that as a reference to look at the parts. So you have the inferior superior vena cava leading to the right atrium, and then what veins are leading to the left atrium? Pulmonary veins. So those veins are filling the ventricles through open AV valves, and the atria are not doing anything yet. It's passive filling, we call it. Passive filling as the heart is totally relaxed and filling with blood. 80%. 80% is passive. Then that SA node fires and the atria contract, and that fills the other 20%. So 80% is passive through open AV nodes, AV valves, left and right AV valves. So that's what we're seeing here, passive ventricular filling. Blood is coming in, filling the ventricles. Then here you can you see that the atria are contracting there? You have the little wiggly lines there. And then it fills The rest? So the heart starts to contract now. But remember, as it contracts, this is full of blood, so that increasing pressure in the ventricles slams those AV nodes shut. And that's our first heart sound. So I want you to add, the first heart sound occurs during isovolumic contraction. And the reason why we say isovolumic is pressure is increasing, but look at all the valves. Are they open or closed during this period? The semilunar are the pulmonary and aortic valves. Are they open or closed during this period? Let's look at the diagram. They're closed. And how about the AV valves? Closed. So that's why we call it isovolumic. Iso meaning same. It means the volume is not changing yet. Blood is not entering or leaving the heart during this time, but it's going to happen very soon because those ventricles are starting to contract. So this is the end of the conduction pathway. The Purkinje fibers are starting to fire, or have fired, and the ventricles are starting to contract. So there's just enough pressure to slam those AV valves shut, and we hear the lub. So take a look at that handout I gave you now. I'm going to pull it up here. Cycle. Here it is, right at the top. Whoa. Okay, so if you look at this diagram, then we're looking at isovolumic contraction. I've shaded that part of the graph in yellow. Do you see the little thin yellow parts there? So this is just a second cardiac cycle. So there's 2 cardiac cycles shown on this graph. So this little yellow shaded part is isovolumic contraction. So let's look at what happens. Here's the first heart sound. See the phonocardiogram? That's the heart sound. That's the lub right there during that narrow little isovolumic contraction. What's happening during this time? Can you see the EKG? We're in the QRS complex, right? Because the ventricles are contracting. What's happening to pressure? If we look at this graph here is called, in orange, is ventricular pressure. Look at how the pressure is rising during this time. Increasing, increasing, increasing pressure. Then we get to the next phase, which is the ejection phase. So what's open in the ejection phase? If you go back to our, keep that there. Where is my PowerPoint? Here? Okay. So what's happening during the ejection phase? What's open? Yeah, our aortic valve here and our pulmonary valve here. So blood is leaving the heart during the ejection phase. So going back to your graph, the ejection phase, I can see pressure is rising, and then what happens? Pressure is going down, because I'm at the end of contraction. And now the heart relaxes in this narrow little isovolumic relaxation phase. So if we go back to our PowerPoint, what's happening during the isovolumic relaxation? Is blood entering or leaving if we're using the prefix isovolumic? Same volume? No. All the AV valves and the semilunar valves are closed. The heart is relaxing. So this is where we hear the second heart sound, and that's due to what valves closing? Yeah, the aortic and pulmonary valve, because as the heart relaxes here, we can see the ventricles are relaxed, blood starts to come back to the heart, and that puts pressure on these valves and closes them. So that's the DUP, right? So that's the second heart sound. If we go back to our worksheet, this is the isovolumic relaxation phase here. There's my second heart sound on the EKG. All right, and what's happening to ventricular pressure? It's going down. And all the valves are closed. Now, at the end of that, our cardiac cycle starts over again. Here the ventricles are filling. Ventricular volume, this graph, the ventricles are filling. And we call that passive and active filling. So this part that's not shaded is passive filling, because look at the pink part. This is saying atrial systole. So that means the atria are contracting to fill the last part of that ventricle, so this is the active filling portion. And then we start our cycle again. So you should start the cycle, kind of right here at the, the end of filling, and then it fills again as a result of active filling by the atria with that last 20%. So AV valves, key points again. AV valves are all of the valves are closed during isovolumic contraction and isovolumic relaxation. And we hear the heart sounds during this period. Which heart sound do we hear in this one? Which one? The lub, the first heart sound. And which heart sound do we hear here? The dup. So just know lub is during the contraction part of isovolumic, and the dup is during the relaxation part of isovolumic. And again, most of the ventricles fill in what way? Passively. Everything's relaxed, AV valves are open, and the veins are just dumping their blood from the lungs and the body. So we can measure heart function on how well this cardiac cycle is doing by measuring things like cardiac output. And the biggest way that we look at heart function in a person is through, one, a stress test and looking at the EKG while they're exercising. And another one is through an echocardiogram, where we use ultrasound and we just pass it over the heart. Well, there's two types. There's one that go down the throat to look at it, and there's others that go over the chest. But we look at, how the valves are functioning, how the ventricles are doing. We can look at blood flow all through ultrasound. Do you have a question, Emma? To make sure they have a really good contact for electrical activity, yeah. Because sometimes dead skin cells and stuff can interfere, and they're not going to, the patches don't stick as well. So yeah. Some people, that are having a heart attack are sweating during the heart attack, and all their patches fall off. And then we're trying to get the patches on and trying to control the chest pain, and it's stressful. So cardiac output, know the definition of these terms. It's the amount of blood pumped by each ventricle in a minute. So it involves a time frame. So it depends on your heart rate, right? So the formula for cardiac output, you have to know the heart rate, how many times it's contracting in a minute, and then knowing what the stroke volume is. And the stroke volume is the amount of blood pumped by each ventricle in one beat. So it's like taking a sponge and squeezing it into a jar, squeezing the water into a jar. The more I squeeze it, the more that's going to leave my sponge, right, and enter the jar. So think of stroke volume as depending on the amount of squeeze that heart can contract with. Which do you think can squeeze better? An exercised heart that's been running and bicycling and walking their dog on a regular basis, or someone who sits in front of the Xbox all day? Which heart is stronger? The one that exercises, right? Any muscle, if you want to get your biceps stronger, what do? You work it, right? You make it work harder. If you want to get your heart muscle stronger, you got to work it, right? I see these people at the Y sometimes that are on the treadmill and they're just walking along. They're not sweating, they're not deep breathing, they have it set on the lowest setting, and they're just moving their body. So they're burning calories, that's great, but are they getting cardiovascular exercise? Absolutely not. You have to get your heart rate a little higher and be breathing higher, which indicates you're working your heart. So people that have heart failure are those people that have had chronically high blood pressure due to sleep apnea, high cholesterol, or just genetics, and they're not working their heart. So the heart gets weak and flabby, and stroke volume goes down. Will that affect cardiac output? Well, if I look at the formula, stroke volume's in there, right? So if this is a low number, then my cardiac output's going to be low. So when they get up to go to the bathroom and they have low cardiac output, are they getting oxygen delivery to the tissues? If the heart isn't pumping enough blood there, no. So they have low oxygen levels, so they're breathing heavily. Anytime a person is short of breath, if it's not due to a lung cause, we have to look at the heart. And that's what happened to me a couple of times. Like I ran the turkey trot at UWL, and it was viciously cold that day, really, really cold. And at the end, you run on the track, and it was really windy. And I finished my run, and I had really intense pain in my chest. And I'm like, okay, is this a heart attack, or is this my lungs are on fire from this ice cold air and breathing deeply? So my test to myself was, did I recover normally after the run? When I was done running, did I stop the heavy breathing within a couple of minutes? And I did, and I was not short of breath, but the burning pain was there. And I knew that it was my lungs that were hurting from the cold air, and it wasn't my heart, because there was no shortness of breath with walking around in activity. So that's where we really have to ask people, are you short of breath with activity when you have this chest pain? Because the two really go hand in hand. Sarah, did you have a question?
Yeah, I was just wondering, because people with like heart disease, like their bodies, like they don't exercise, right?
Mhm.
Like so their heart is like bigger.
Yep.
But how does the like exercise differ from? I know it's probably impacts the heart differently, but it's still like exercising the heart
Mhm.
because there's something like big.
Yeah, right.
So then people are like exercising.
Right. Exercise is important for people with heart failure as well. They have to be more careful because they might have some arrhythmia problems too that can be, aggravated by exercise. So they really have to be careful. But I have a relative who, didn't take care of himself for a lot of his life and ended up with bypass surgery a couple of times, has a pacemaker, heart failure, edema, all this stuff. Saw him last summer and he looked great. I'm like, oh my gosh. I said, you really look good. You must be feeling better. Yeah, I finally started participating in that cardiac rehab. So I go to the treadmill 3 times a week, and I have a nurse there, and I've been exercising and been feeling a lot better. I'm like, oh my gosh, you look so much better. So when people have had a heart attack, we encourage them to participate in cardiac rehab. But if they're sedentary and they just don't want to do that, and they want to go back to smoking and eating Kentucky Fried Chicken in front of the television, they're just going to be in bad shape. And those are the patients that are, in and out of the hospital all the time. But cardiac rehab is great. It's exercise for people that have had heart conditions. So we get a better squeeze when we exercise. One more minute here. So heart rate goes down in people that exercise, and their cardiac output is the same or better. And why how can heart rate go down in a person that exercises? What does that tell us about stroke volume then? It's better. They exercise that muscle so their heart can squeeze better. It doesn't need to beat as fast to meet the demands. So if you look at a person who's a runner or some other cardiovascular exercise, they can have heart rates in the 50s at rest because their heart does not need to squeeze as hard because it's got a really good stroke volume. So the heart rate is lower in those people. So when we talk about the amount of blood that it pumps, about 60% of its volume is left with each beat. So 40% remains in the heart, 60% is squeezed out. We call that the ejection fraction. So we want people to be above 55 to have good squeeze and not be in what we call heart failure. So we'll pick up with this on Monday. We're not going to test for a little bit yet because we have a lot of topics to cover yet. So just hang in there, and we'll pick up next time.